Have you had previous surgery to your spine, but maybe you've got a recurrence of symptoms, and now you're wondering if you need surgery again and what this may mean? My name's Anthony Ghosh. I'm a consultant spinal neurosurgeon and founder of the Spine MDT. In this video, I'm going to discuss revision spine surgery, some common scenarios where it may be needed, and what the implications are. Revision spine surgery simply means a second operation to a part of the spine that has already been operated on. This doesn't mean that the first operation was a failure, but there's simply been progression of the underlying disease process, or sometimes a complication that couldn't have been predicted. Nonetheless, revision operations are usually more complex and careful decision making is necessary. A common scenario is a recurrent disc herniation causing sciatica. Maybe you've undergone a previous microdiscectomy for this, things have got better, but sometimes the symptoms have recurred. Sometimes this can be early, or sometimes it may be weeks, months, or even years. Nonetheless, the procedure is a revision microdiscectomy. That involves going through the same scar tissue again, the same as the previous surgery, down onto the disc demonstrated here, and shaving away that recurrent fragment. Often the results are really good. There is possibly an additional risk because of the scar tissue of a tearing in the lining of the spine and therefore a fluid leak. Sometimes the infection risk can be a little bit higher, or injury to the nerve. However, overall, these risks are very low and the results are usually very good. Another condition treated with surgery is spinal stenosis, demonstrated here on this MRI scan, where we can see these nerves are a bit trapped and pinched inside the spinal canal due to a combination of ligament thickening, a bit of a disc bulge, and sometimes a bone slipping a bit forward over the one beneath it. People usually undergo a lumbar decompression for this, which is a fairly simple operation where we make some space by removing some of this overgrown tissue. But sometimes the symptoms can recur with time due to progression of the disease, where the facet joints demonstrated here just thicken up and overgrow, more scar tissue and ligament thickens up and overgrows, and this bone can slip forward even further. Often doing a simple decompression again might not be enough because removing further tissue may destabilize the segment. So in this scenario, we have to carry out a procedure called a lumbar fusion, which I've described in another video, which involves putting in this construct here of screws and rods and a little device between the vertebral bodies called a cage to allow the segment to fuse and stabilize when we go in and decompress the nerves again. This is obviously a more complex and lengthy procedure, but can still be done through minimally invasive techniques. Now, on the subject of lumbar fusion or any spinal fusion, there is a risk of adjacent segment disease. So demonstrated here, we have a segment of the spine that has been fused together and therefore immobilized. So to make up for that loss of range of movement, the level above has to be able to move a bit further, and that can theoretically accelerate wear and tear in this segment. And if that becomes symptomatic, that may need surgery where we extend this construct to include the segment above. Sometimes we can see fractures or failures of the metalwork, which also needs revising. So surgery is often a lot more complicated when we are working with pre-existing metalwork, either where adjacent segment disease has happened and we have to extend the metalwork, or if we have to remove and replace the metalwork if it's been broken or has come out of the bone and not healed. Another scenario is infection. Now, if there's no metalwork in the spine, often that can be treated with antibiotics, and if that fails, sometimes we have to reopen the wound and wash out the cavity. However, things again get more complicated if there is metalwork to deal with. Sometimes just washing out the cavity or giving antibiotics isn't enough, as the bacteria cells living on the metalwork are different to get to with even the strongest antibiotics. So often the metalwork has to be removed. So the decision making is really important between the patient and the surgeon. I often get into a room with other colleagues, and we call this a multidisciplinary meeting, which I really believe in, where we all put our heads together, go through the images very carefully, and often that's a better way of making the right decision. I believe in this multidisciplinary approach even with the first operation, especially if we are considering using metalwork. Very careful planning is what's going to help prevent the need for a further operation due to some form of complication or failure. I really hope you found this video helpful. If so, please click that like button and do subscribe to the channel. Also visit us at spinemdt.com to see how we can help you. Thank you very much for watching.